Good evening. Tonight we're reading from Advances in Psychiatric Treatment. The article is Neuropsychiatric Effects of Caffeine. The authors are Anthony P. Winston, Elizabeth Hardwick, and Nima Jaberi. Abstract. Psychiatrists rarely inquire about caffeine intake when assessing patients. This may lead to a failure to identify caffeine-related problems and offer appropriate interventions. Excessive caffeine ingestion leads to symptoms that can overlap with those of many psychiatric disorders. Caffeine is implicated in the exacerbation of anxiety and sleep disorders, and people with eating disorders often misuse it. Caffeine antagonizes adenosine receptors, which may potentiate dopaminergic activity and exacerbate psychosis. In psychiatric inpatients, caffeine has been found to increase anxiety, hostility, and psychotic symptoms. Assessment of caffeine intake should form part of routine psychiatric assessment and should be carried out before prescribing hypnotics. Gradual reduction in intake or gradual substitution with caffeine-free alternatives is probably preferable to abrupt cessation. Decaffeinated beverages should be provided on psychiatric wards. Quote, Honoré de Balzac, paraphrasing Brelat-Savarin, quote, coffee sets the blood in motion and stimulates the muscles. Coffee accelerates the digestive processes, chases away sleep, and gives us the capacity to engage a little longer in the exercise of our intellects. This was in his Traité des Excitants Modernes, translated from the French, 1838, translated from the French by Robert Onopa. Right, caffeine is the most widely used psychoactive drug in the world. It is found in more than 60 known species of plants, and dietary sources include coffee, tea, cocoa beverages, chocolate, and soft drinks. Coffee was consumed in Arabia in the 13th century and was introduced into Europe in the early 17th century. Tea was probably drunk in China before the birth of Christ and was brought to Europe in the 16th century. Most dietary caffeine is still consumed as tea and coffee, and the latter accounts for 55% of per capita intake in the United Kingdom of Great Britain and Northern Ireland. Great Britain consisting, of course, of England, Scotland, Wales. Despite, or perhaps because of its ubiquity, caffeine is rarely thought of as a problematic drug. Doctors do not often ask patients about its use, and inquiry into caffeine consumption is not usually included in the psychiatric assessment. That seems to me very suspicious, because shouldn't one of the most fundamental first questions of an incoming psychiatric patient be, how much caffeine, nicotine, and other legal drugs do you consume? On average, a cup of brewed coffee contains 100 milligrams of caffeine. Well, how much is a cup? 8 ounces. Compared with 75 milligrams for instant coffee and 50 milligrams for tea, a can of Coca-Cola contains 30 milligrams of caffeine. Increasingly, stimulant drinks such as Red Bull, 80 milligrams of caffeine per can, are being marketed to the public, and sales have increased dramatically since they first became available in 1987. Pharmaceutical caffeine may be bought over the counter, for example as Pro Plus tablets, and is also contained in numerous proprietary analgesics, cold and flu remedies, diet pills and diuretics. Anadin extra, for example, contains 90 milligrams of caffeine per dose. In the United Kingdom of Great Britain and Northern Ireland, including England, Scotland and Wales, mean caffeine consumption is estimated at 359 milligrams per day. Effects and diagnostic classification. The primary effect of caffeine is to relieve fatigue and enhance mental performance. Excessive ingestion leads to a state of intoxication known as caffeinism, which is characterized by restlessness, agitation, excitement, rambling thought and speech, and insomnia. These symptoms clearly overlap with them of many psychiatric disorders. The potential harmful effects of caffeine have long been recognized. As long ago as 1900, the Journal of the American Medical Association reported a conference on coffee as a beverage, drink, its deleterious effects on the nervous system, at which a contributor complained that most physicians had given the subject little, if any, attention. Another contributor asserted that coffee could cause a variety of symptoms, including depression, irritability, insomnia, tremulousness, the shakes, loss of appetite, and frequent eructations of gas. 4 caffeine-related syndromes are recognized in DSM-IV, American Psychiatric Association, 1994. Caffeine intoxication, caffeine-induced anxiety disorder, caffeine-induced sleep disorder, and caffeine-related disorder not otherwise specified. Caffeine withdrawal is included in the appendix to DSM-IV under criteria sets and axes provided for further study. The ICD-10, World Health Organization 1992, is less specific. It recognizes mental and behavioral disorders due to use of other stimulants, including caffeine, which are then subclassified in the same way as other substance use disorders. Acute intoxication, harmful use dependent syndrome, withdrawal state, etc. However, there is no specific guidance on diagnosing problems due to caffeine misuse. And the diagnostic criteria are the same as for other substance use disorders. The prevalence of the various caffeine-related syndromes is uncertain. Despite this formal recognition, caffeine generally receives little attention from psychiatrists. For example, the New Oxford Textbook of Psychiatry, Gelder et al. 2003, does not discuss caffeine misuse, although caffeine is mentioned briefly as a cause of insomnia. Consequently, psychiatrists rarely inquire about caffeine intake when assessing patients. I find that odd, perhaps even suspicious. This may lead to a failure to identify caffeine-related problems and offer appropriate interventions. This article describes the clinical effects of caffeine consumption in a variety of psychiatric disorders and offers some guidance on assessing and managing caffeine-related problems. Biochemistry and Pharmacology of Caffeine. Caffeine is a methylxanthine. The effects of this group of chemicals include stimulation of the central nervous system, diuresis, stimulation of cardiac muscle, and relaxation of smooth muscle. Caffeine initially stimulates the CNS at the level of the cerebral cortex and medulla oblongata, and only later stimulates the spinal cord at higher doses. Its effect begins within 1 hour and lasts for 3 to 4 hours. Baker and Theologist, 1972. Caffeine is rapidly absorbed from the gastrointestinal tract and then metabolized by demethylation and oxidation in the liver. There is some individual variation in the rate of metabolism. The half-life is reduced in smokers but increased in pregnancy and in ladies taking oral contraceptives. Biochemically, the main action of caffeine is antagonism of adenosine A1 and A2 receptors. Higher doses cause inhibition of phosphodiesterases, blockade of Y-aminobutyric acid type A, parentheses, capital G, capital A, capital B, capital A, sub capital A, parentheses, SIC, S-I-C, added by me. Receptors and release of intracellular calcium. This is from a study by Daly and Fredholm, 1998, and Finnegan, 2003, or 2003 for those so bent. Neuropsychiatric effects are mediated largely by blockade of A1 and A2A receptors in the central nervous system. Adenosine A1 receptors are present in almost all brain areas, but particularly in the hippocampus, cerebral cortex, cerebellar cortex, and thalamus. There are importanti connessioni between adenosine receptor and the dopaminergic system, which may be relevant to the effects of caffeine in psychosis. See below in the subsection schizophrenia. Adenosine capital A sub 2A receptors are concentrated in the dopamine-rich regions of the brain and are thought to have considerable links with dopaminergic receptors. Moreover, there is evidence that the stimulatory effects of caffeine require intact dopaminergic neurotransmission. These stimulatory effects appear to result primarily from blockade of A sub 2A receptors, which stimulate inhibitory GABAergic neurons and pathways to the dopaminergic reward system of the striatum. Blockade of adenosine receptors also reverses the inhibition of adrenaline release in the sympathetic nervous system and results in sympathetic stimulation. Elsewhere in the body, caffeine causes relaxation of smooth muscle, especially bronchial smooth muscle, and stimulation of cardiac muscle. These effects resemble those of beta-adrenoceptor stimulation. The stimulatory effect on the heart can result in tachycardia at high doses. Psychological effects. The psychological effects of caffeine are biphasic. Low doses produce stimulation, which is often perceived as desirable, whereas high doses can cause the unpleasant effects of caffeineism. Caffeine increases alertness, reduces fatigue, and can elevate mood. Normal consumption improves performance on tasks that require alertness, such as simulated driving tasks. The effort on more complex cognitive tasks is less clear, although there is evidence to suggest that high consumption is associated with better performance, especially in older people. Adverse effects. Caffeine has a number of adverse effects on the gastrointestinal tract. It relaxes the lower esophageal sphincter and can predispose to gastroesophageal reflux disease. It also causes gastric hypersecretion, which is associated with susceptibility to ulceration. It increases the rate of gastric emptying, and the acidic gastric contents, therefore, pass more rapidly into the duodenum. This can lead to inflammation in the duodenal mucosa. The diuretic action of caffeine is well known. The public is often advised to abstain from consuming caffeine in situations where dehydration may be significant, such as long-haul flights. A recent review concluded that single doses of caffeine, such as those found in commonly consumed beverages, have little or no diuretic action, although large doses, that is, ones greater than 250 milligrams, do. Caffeine may precipitate sinus tachycardia, but does not increase the risk of cardiac arrhythmias, except perhaps a very high dose. It can trigger migraine in susceptible individuals. Excessive use of caffeine-containing analgesics has been linked to analgesic nephropathy. Caffeine may also be harmful in pregnancy. Intakes above 300 milligrams per day may be associated with low birth weight and miscarriage. The United Kingdom Food Standards Agency has recommended that pregnant women should limit their intake to less than this amount, which is equivalent to 4 average-sized cups or 3 average-sized mugs of instant coffee or 6 average-sized cups of tea. Dependence and withdrawal. Caffeine acts as a reinforcing agent in both humans and animals, although its effect is less powerful than that of stimulants such as cocaine and amphetamine. The reinforcing effect is thought to be due to both pleasurable stimulatory effects and unpleasant withdrawal symptoms. Caffeine differs from classical drugs of misuse in causing dopamine release, prefrontal cortex rather than the nucleus accumbens, which is the principal area involved in reward and addiction. Withdrawal symptoms have been reported in both humans and animals. Well-recognized symptoms include headache, irritability, sleeplessness, confusion, nausea, anxiety, restlessness, and tremor, palpitations, and raised blood pressure. They typically start slowly, are at their worst at 1 to 2 days, and recede within a few days. They are rapidly relieved by intake of caffeine, suggesting that they are genuine withdrawal symptoms. Tolerance has been reported to the effects of caffeine on the respiratory and cardiovascular systems, but there is little tolerance to its effect on sleep or mood. Data on the prevalence of withdrawal symptoms are inconsistent, with a range of 11% or less to 100%. One study found that 7.5% of the population may experience adverse effects following either caffeine consumption or withdrawal. In another study, 11% of caffeine consumers reported withdrawal symptoms. Among regular caffeine users, only 0.9% of males and 5.5% of females reported withdrawal symptoms significant enough to interfere with normal activities. Withdrawal symptoms appear to be more common in teenagers. In one sample, 77.8% reported withdrawal symptoms and 41.7% tolerance. Overall, clinically significant withdrawal symptoms seem to be relatively uncommon in the general population. It has been suggested that there is a definable caffeine dependence syndrome on the basis that some adults meet the DSM-IV criteria for substance dependence. However, many studies of caffeine withdrawal have methodological limitations, and the status of caffeine as a drug of dependence remains controversial. Caffeine and psychiatric disorder. The consumption of caffeine may be higher in psychiatric patients than in the population as a whole. Caffeine use has been linked with specific disorders such as anxiety disorders, sleep disorders, and eating disorders. There is a possible association with schizophrenia. Surprisingly, there are no published reports linking caffeine use with mania or hypomania. Odd. Very odd. Anxiety disorders. The resemblance between the symptoms of excessive caffeine ingestion and those of anxiety is obvious, and they may both have a basis in overactivity in the sympathetic nervous system. It has been argued that the symptoms of caffeinism are indistinguishable from them of anxiety. However, caffeinism is normally associated with the daily intake of 1,000 to 1,500 milligrams of caffeine, and the relevance of Graydon's observation to lower doses is uncertain. There is a substantial literature documenting the angiogenic effects of caffeine in both experimental and realistic situations. The stimulation of anxiety in response to caffeine may be due to increased levels of lactate in the brain. The role of adenosine in mediating caffeine induced anxiety is, I'll repeat that, the role of adenosine in mediating caffeine-induced anxiety is supported by the finding that there is an association between different anxiety levels after caffeine administration and polymorphisms on the A2A receptor gene. So, clinically, caffeine may be involved in the precipitation, exacerbation, or maintenance of anxiety disorders. Sensitivity to caffeine is increased in people with panic disorder and social phobia.
Well, excuse me for just a moment, my friends.
Sensitivity to caffeine is increased in people with panic disorder and social phobia, and administration of caffeine can provoke panic attacks in these individuals. There are clinical reports of anxiety symptoms improving on caffeine withdrawal or limitation, and people suffering panic attacks may benefit from a reduction in their intake. Sleep disorders. It is well known that caffeine produces insomnia or sleeplessness. It reduces slow wave sleep in the early part of the sleep cycle and can reduce rapid eye movement sleep later in the cycle. Caffeine increases episodes of wakefulness, and high doses in the late evening can increase the time taken to fall asleep. In old people, the use of medication containing caffeine is associated with increased risk of difficulty in falling asleep. Eating disorders. Clinical experience suggests that people, one moment please. Clinical experience suggests that people with eating disorders such as bulimia nervosa and anorexia nervosa often consume large quantities of drinks containing caffeine in the belief that caffeine increases metabolic rate and suppresses appetite. In people with anorexia nervosa who are already at high risk of cardiac arrhythmias, the stimulant effect of caffeine on the heart may be dangerous. Excessive caffeine ingestion may also contribute to osteoporosis, which has a high prevalence in anorexia nervosa. Surprisingly, caffeine consumption in folks with eating disorders has received little attention in the literature. There is only one published study carried out in the United States of America that focuses on caffeine intake in this population. This study of individuals with anorexia nervosa, bulimia nervosa, and eating disorder, not otherwise specified, found that 14.6% had a high caffeine intake over 750 milligrams per day, 39.2% had a moderate intake, that is 250 to 750 milligrams per day of caffeine, and 46.3% had a low intake, that is less than 250 milligrams of caffeine per day. High and moderate intakes were associated with an increased frequency of binge eating compared with low intake. Those in the high intake group were almost more likely to misuse laxatives and diet pills and have higher levels of anxiety. High and moderate intake were associated with high scores on the Michigan alcohol screening test. We are currently conducting a study of caffeine use in British people with eating disorders, schizophrenia. It has already been noted that there are connections between adenosine A sub-2A receptors and the dopaminergic system in the brain. As adenosine inhibits dopaminergic neurotransmission, blockade of A2A receptors by caffeine may increase dopaminergic activity and exacerbate psychotic symptoms. Clinically, the symptoms of caffeine intoxication can mimic those of psychosis or be confused with the side effects of medication. Cessation of caffeine causes fatigue and drowsiness, which can be confused with the side effects of psychotropic drugs. There's also evidence that people with schizophrenia have higher than average intakes of caffeine, although the literature is inconsistent. There are a number of case reports of high caffeine intake among inpatients with schizophrenia. Studies published in the 1970s give conflicting results. One finding that 71% of inpatients use more than 500 milligrams of caffeine per day, and the other that only 17% use more than this amount. A more recent study found that the mean daily caffeine intake of 26 inpatients was 503 milligrams, with 38% using more than 555 milligrams. Several theories have been advanced as to why people with schizophrenia might have high intakes of caffeine. These include using caffeine to relieve boredom and apathy and to offset the sedating effects of antipsychotic medication. Many psychotropic drugs produce a drug. I've also seen that schizophrenics seem to smoke. I've never met a schizophrenic that didn't smoke. And I've been in the mental health business, the mental illness business for many years. And many psychotropic drugs produce a dry mouth, which might increase the intake of caffeinated drinks. About 80% of people with schizophrenia smoke. Oh, it's only 80%. Well, in British Columbia, less than 20% of people, adults, smoke. And these individuals may use more caffeine to make up for the increased elimination of caffeine due to heavy smoking. Oh, so my observation was accurate. As I said, I've never met a schizophrenic that did not smoke cigarettes, that did not overindulge in coffee intake, and often alcohol. There have been, I guess the alcohol takes the edge off the, being a depressant takes the edge off the stimulants, nicotine and caffeine. In any event, there have been a number of case reports of delusions and hallucinations after large intakes of caffeine by people both with and without psychosis. There's so many parentheses in here, it's distracting. One study of 78 people with schizophrenia found that caffeine intake was correlated with positive symptoms but not with negative symptoms. Another small study found only a slight correlation between caffeine intake and severity of psychosis. I would say that the studies that are not, I repeat, not paid for by the caffeine industry are the ones to go by. I'm talking about, when I say caffeine industry, I mean the makers of cola drinks, the makers of coffee, teas, and chocolate. Another small study found only a slight correlation between caffeine intake and severity of psychosis. 3 studies have attempted to determine the effect of caffeine on psychotic symptoms in inpatients by comparing the effect of caffeinated and decaffeinated beverages. Drinks. I don't know, Americans say beverage, why don't they just say drink? All used the brief psychiatric. I find it unfortunate that often the word drink is limited to drinks with alcohol in it. I myself use drink for anything that's drunk, such as water, soft drinks. Right, the effect of caffeine and decaffeinated beverages. All use the brief psychiatric rating scale, self-reported in the nurse's observation scale for inpatient evaluation. The first found that scores on the anxiety and hostility subscales and irritability scores on the NOSI were higher when caffeine was being consumed. The second found that scores for hostility, hallucinations, and unusual thought content on the BPRS and for irritability and psychosis on the NOSI were correlated with caffeine intake. However, these changes were small and statistically questionable. The third study found no relationship on either scale betwixt caffeine intake and anxiety, depression, or total scores in an experimental study. Caffeine was administered intravenously to 13 patients with schizophrenia who had been caffeine-free for 6 weeks. The dose used 10 milligrams per kilogram of body weight. What do they mean, kilograms of body weight? I was taught that the metric system, the kilogram was not a measure of weight, sondern mass. It was the equivalent of drinking 7 cups of brewed coffee in a row. Caffeine increased both the total score and the unusual thought subscale score on the BPRS. Conversely, caffeine decreased withdrawal retardation. Interestingly, this large dose did not increase anxiety scores. The wind's blowing. It sounded like the wind was going to blow out the window for a second. Oh, by the way, it is 2300 hours, 20 minutes, Tuesday, 25 March 2014, in the Pacific Daylight Time Zone. The reason why I'm reading about caffeine is because I've been overdosing. I've been overdosing on caffeine for several days now. Tomorrow I'm going to go cold turkey. Off of coffee and tea. I'm still going to have my 1 or 2 12-ounce cans of Coca-Cola because I do not want that dreaded caffeine withdrawal migraine headache, which I've experienced before. Was the equivalent of drinking Conversely, caffeine decreased withdrawal retardation. Interestingly, this large dose did not increase anxiety scores. I find that very difficult to believe. Interaction with antipsychotics. I'm not going to read that. Okay, folks, it's obvious that excessive caffeine consumption can lead to psychosis and schizophrenic-like behavior. For example, I consumed about 2,000 milligrams of caffeine today. So I'm feeling a little schizzy and psychotic-y. So, very good. I hope I have entertained you sufficiently for you to tune in again tomorrow. Wir verabschieden uns mit dem Wort zum Sonntag. Gott, der Herr, ist die ewig helfende Medizin für unsere todkranke Welt und Menschheit. Auf Wiederhören.